Welcome to Your Case is on Hold, a JBJS podcast hosted by Antonia and Andrew Schoenfeld.
Here, we discuss the science in each issue of JBJS with an additional dose of entertainment and pop culture.
Take us with you in the gym, on the commute, or most certainly, whenever your case is on hold. Welcome back, everyone, to Your Case is on Hold. This is episode 81. If you are listening on the day we drop, it's May 6th for the May 7th issue of the journal Bone and Joint Surgery. As always, I'm the deputy editor of Methods, or the DEP, or the Imperial Deputy Editor, if you're not into the brevity thing. You're Andrew Schoenfeld, MD, and I have with me
Shen, just DEP, because it's too many words, because adult reconstruction is the longest title for any orthopedic subspecialty. So DEP works well.
I'm with Dr. Chen for who she really is. Everyone else is with Dr. Chen for who they think she is.
Philosophical deepness.
Yeah, what was it, like the last episode we did, or maybe 2 episodes ago, it was like the epistemological, like, this is totally correct, but yet also totally wrong. It's kind of like bilateral total knee replacements.
Totally deep, and yet not everyone loves it. In fact, most people don't.
No, it's like, this is a totally good thing to do, but actually the worst thing that you could do.
Win and a loss in the same thing.
It depends on your perspective. Anyhow, as is that take you just heard on bilateral total knees, don't do them. These opinions are our own. You do them?
I do them.
You do them by yourself, like sequentially, or you do them with a partner?
No, I don't do it with the partner. I do it myself, but in the same anesthesia time. Depending on the patient, it's very selective.
Yeah. We'll talk about some patient selection here later. We'll foreshadowing, sneak preview. Anyhow, yeah, so that's my opinion, not Dr. Chen's opinion, except in select circumstances, I guess. And these opinions are our own and not those of JBJS or the editorial board therein, or the other constituent journals, or the editor-in-chief, Dr. Bandari, or the board of trustees. As always, like, subscribe, give us 5-star rating, share, find us on Stitcher, Castos, Apple, Spotify, jbjs.org. If you can't get us anywhere else, watch us on YouTube. I just had somebody reach out. They thought the only place that you could see us is YouTube, which is not true. So let people know. What else? This issue is brought to you by the Miller Review course. We're coming up right up against the time that the course is going to take place. So if you haven't signed up yet and you want to get everything, all the secrets to board certification, maintenance certification, all about what's important and what you should know in the field of orthopedics, it's a great place to do that in one setting, working with some real luminaries in the field and some really great people across the board. Are you going? Are you faculty there?
Not this year, but last year I was, and it's an excellent program.
A lovely venue as well.
Mm-hmm. Very much so.
All right. So in this issue, we have in the top of the pile, it's like, hang on, because you're going to think we're done with the journal, and it's just going to be the top of the pile articles. So deep breath, sip of the energy drink, driving impact together by Dr. Bandari. This is permanently free. If you look at anything, definitely check this out, because it's going to plug you into the new face of JBJS in terms of the article types and different areas of focus that is sort of a pivot from where we've been in the past and a new horizon for the future. That's my take on it. That isn't text that I've been given. So you should look at that. Sagittal spinal profile in patients with lumbosacral hemivertebra, preoperative status and postoperative evolution at a mean follow-up of 7.5 years by operative treatment of flail chest injuries does not reduce pain or in-hospital opioid requirements. Results from a multi-center randomized controlled trial by Dagan and colleagues. Total ankle arthroplasty in obese patients, an ethical analysis by LaChance. Evaluating data sharing policies and author compliance in leading orthopedic journals by Major and colleagues. Learning to Feel, surgery technology and the limits of digital training by Kumar. What's important, diverse history to diverse practice, how the Society of Military Orthopedic Surgeons E. Anthony Rankin Scholarship molds future orthopedic surgeons by Warren. Risk stratification, something we already talked about in orthopedic surgery, an important adjustment for value-based healthcare and quality measurement by Boyle and colleagues. Radiation shielding effect of surgical loops compared with lead-lined glasses and plastic face shields by Hardiker and colleagues. Preservation versus release of normal long head of biceps tendon and repair of isolated stage 1 supraspinatus tears. Preservation leads to slightly lower constant Murley scores and more reoperations by Bearway and colleagues. Refractures in children by Parkerainen and colleagues. That one is permanently free. Femoral neck system compared with 3 cannulated screws in the treatment of femoral neck fractures in patients age 60 and older, a multi-center registry-based study by Mallon and colleagues with a visual summary and 30 days free. Relationships between promise and legacy patient-reported outcome measure scores in the MARS cohort at 10 years follow-up by Wright and colleagues. The minimal clinical important difference for total joint arthroplasty outcome measures varies substantially by calculation method by Solomito and colleagues. Examining preoperative risk factors for nerve injury in pediatric Montasia fracture dislocations by Amaral and colleagues. And that's now we're headed into the headline. What's new in orthopedic research this week? My headline, identifying risk factors from preoperative MRI measurements for failure of primary ACL reconstruction, a nested case control study with 5-year follow-up. This is by Zhang and colleagues. So this is a study that was conducted on patients who underwent ACL reconstruction using hamstring tendon autograft at a single institution from August 2016 to January 2018. Authors state that they are aiming to identify potential risk factors for primary ACL reconstruction failure using preoperative MRI measurements and then to determine optimal cutoff values for clinical relevance. And they hypothesized that increased preoperative values would be associated with failure, as isolated ACL reconstruction may not sufficiently address internal rotational instability. So they're really looking at values like the greater lateral femoral condyle ratio, greater posterior tibial slope in the lateral compartment, greater internal rotational tibial subluxation. And they do this in a cohort of patients, initially, all comers in that time window, August to January, not even a 2-year time period. They had almost 3,000 patients, which I was impressed with, 2,882 to be exact, who underwent ACL reconstruction with single bundle hamstring tendon autograft. And then they had a total of 72 patients who experienced graft failure within 5 years. And then they did a matching process. So they took those 72 patients and then they did a match, which they describe as a 1-to-2 nearest neighbor matching. And then they reference like other studies, which isn't always the best thing to do, honestly, because you shouldn't tell your audience, this is what we did, but if you want to know what we did, just go look it up somewhere else. Because it's really unlikely that you did exactly what you did in the other studies, even if they were your other studies. And also that's very tedious for the reader. Like, they should not have to go find some other paper and then imagine how it relates to your own research. Like, you should just tell them. So specifically here, one of the main things which we've discussed in propensity in matching studies such as this, they call it a propensity score match, is the caliper. And there's not good clarity exactly on what the caliper was. And then they're matching, the variables matched between the two groups were sex, age, body mass index, educational level, pre-injury physical activity, time from primary injury to surgery injury. So a couple of pointers here on that front. First off, if you're doing a match, I don't think that propensity score matching particularly lends itself to the study question. The question in the title and what they were talking about in their motivational statement in the introduction is we want to identify risk factors for primary ACL failure. So if you're looking at risk factors, that to me means you want to have a broad representative cohort of patients, something like where you started, the 3,000 patients, or after they whittle things down, they've got 1,006 patients with 5-year follow-up. So take all those patients, look for the failures, and then looking at everybody. I don't understand the need to do the match. And they're matching on sex, age, body mass index, educational level, pre-injury physical activity. We already went through which characteristics they're matching on. I don't know that all of these are necessarily associated with the risk of failure. They certainly don't show that in an empiric proof here. And that's going to create artifacts ultimately in the model. So they're matching on things that may or may not, but I don't think they have a really good case. And then they only have 72 patients with failure, yet they have sex, age, body mass index, educational level, pre-injury physical activity, time from primary injury to surgery, and pattern. So they have 7 variables that ideally you would need like 140 events, not 72 events. So their propensity score model is probably somewhat over optimistic or maybe even over fit. And then they're matching it with 144 patients who didn't have failure. And so in this more curated, truncated cohort, they're then making these additional determinations. And they say because of potential collinearity among similar measurements, the most significant variable, which they define as the variable with the smallest significant p-value, was selected for their further analyses. I think that you shouldn't really rely on the p-value because that has to do with where you're powered, and with 72 patients, there are probably some issues with power. I think it would have been better to go with the most clinically relevant factors, that you're giving preference to what's more clinically relevant or deemed clinically important from a causal model than just looking at a p-value. So ultimately, they found greater lateral femoral condyle ratio, greater posterior tibial slope, greater interrotational tibial subluxation were identified as factors influencing failure in this curated cohort. So it's already a narrowed cohort. It doesn't necessarily apply to everybody. It applies to people who look the same in those parameters that they identified. Now, if they did a regression analysis with the entire 1,006, would it have come to the same determinations? Well, maybe, but they didn't show us that. And ultimately, if we're talking about science in its epistemological purest sense, no matter what kind of analysis you do, you should get the right answer. If the analyses are perfect, they should all come to the same conclusion. If you're not reaching the same conclusion, it's because of corruption, impurities, and artifacts, right? So, I would say that they give these values. ROC analyses showed the optimal cutoff, 5.8 millimeters and 8.5 degrees. And then they give you, the AUCs and the sensitivities and specificities. And certainly for the IRTS, neither one, actually, the AUC is that high. This is the discrimination. This is like, if you're just going off of that, what's the percent of the variation that can be explained in the outcome of interest, where 50% is the coin toss. And here you're only at 66% and 71%. So, those are not overwhelmingly amazing metrics. And then for the 8.5 degree estimation, the sensitivity and specificity are 62.5 and 71.5% respectively. So you're usually willing to sacrifice one for the other if at least one of them is quite high, but in neither one of those especially high. So this has some sneaky measures that I think, someone may be inclined to write test questions about, but I really hope that they don't. that's the end result. I think it's some food for thought, but I really also think that there's a lot of potential for the way they went about this the specific approach that they took. Instead of using everybody with the outcomes of interest included, they narrowed it down artificially based on a number of different parameters, some of which we don't have empiric evidence that they, maybe it does make sense that these, at least to some degree, would inform the risk of failure. But just sort of prima facie educational level, I don't see that. And even pre-injury physical activity, I don't know how pre-injury activity is going to inform the post-injury risk, unless you're saying it's also indicative of post-injury activity, in which case I'm like, well, why don't you include that? So I think it's an interesting read and thoughtfully done in some respects, but probably not ready for immediate clinical application or testable item construction.
Agreed. But if you measured this and you had an ACL tear, would you say to the patient, nope, no surgery? Because I know you're going to have a higher likelihood of failure. So I don't think the measurements alone are enough to push that button over.
Also true. Also true. Yes. And let's get into your headline: factors that influence returning to driving following primary total knee arthroplasty, a prospective investigation by Peckus and colleagues, also with a commentary. So don't just take our word for it.
So this one is pretty clinically applicable, I would say. Patients always ask when they can return to driving after a total knee replacement. And typically I tell a patient 4 to 6 weeks for a right knee and probably less time for a left knee. The right knee is technically or normally the dominant leg. You're going from gas to brake if it's an automatic car. Now, if you have a clutch, totally different story. So that might be a little bit different there. Patient reported mean time to driving following primary total knee arthroplasties in literature have been reported to vary from 29 to 58 days. And so the primary objective of the study was to create a novel clinical prediction calculator to estimate the return to driving time after a total knee arthroplasty. So the authors did this over a 7-month period. And during that time frame, they enrolled 283 subjects who underwent primary total knee arthroplasty. They were screened. 167 were enrolled, and 156 actually completed the study. So, from an inclusion criteria standpoint, they were patients who were 18 to 85 years old. They had to have a valid driver's license, which is probably important for driving. They were regular drivers, meaning they weren't driving once a year, but there was self-reported regular driving. Had a cell phone capable of text messaging, were comfortable with text messaging, underwent a unilateral primary total knee arthroplasty, and had a primary vehicle with an automatic transmission. So they couldn't have manual. Excluding criteria were patients who underwent non-primary total knee arthroplasty, were wheelchair or walker dependent, couldn't do informed consent or didn't speak fluent English, were narcotic users, and had any perioperative complication that changed the postoperative period. And the reason that chronic narcotic users was important is because the return to driving criteria was greater than 2 weeks had passed since the surgical procedure. The patient felt safe when driving, which is obviously a subjective comment. The patient is no longer consuming narcotics. The surgeon has allowed full weight bearing and no braces required. And so with regards to surveying patients, they did it through text message. And we know that patients probably respond better through text message and other things. So subjects got text messages every third day postoperatively to determine when they returned to driving. Subjects completed 8 physical performance measurements or maneuvers at their 2, 6, and 12-week postoperative clinical appointments. And subjects completed return to driving surveys and a structured interview. If you want to see any of these, they're in Appendix 1 for this article. And as per usual, they looked at demographic characteristics, operative factors, patient-reported outcomes, and patient factors. And they did Cox proportional hazard and parametric survival models to create 2 novel calculators predicting return to driving time. So of this 156 patients, there were 60% women and 40% men. The average age was 67.7. And there were 11 patients who were removed due to enrollment due to loss of follow-up, involuntary withdrawal, or having screening or failure. It was approximately 50-50 right and left knees. There were a little bit more right knee than left knee. The average hospital length of stay was really short, taking ASC setting 0.64, and the mean operative time was 91 minutes. The median return to driving time was 18 days, which is definitely shorter than what has been typically reported in literature. 32.1% of subjects returned to driving within 15 days. 82.7 returned within 30 days, 95.5 within 45 days, and 100% by the 12-week mark. Now, looking at just univariate analysis, male drivers returned to driving sooner at 18 days versus female patients, which took 25 days. And patients who underwent left-sided surgery returned to driving sooner at 20 days than patients who underwent right-sided surgery at 24 days. White patients also returned to driving sooner at 22 days than Black patients who took 33 days. The preoperative variable with the largest maximum potential predicted effect on return to driving time was the preoperative KOOS score, which had the biggest impact at 5 days, followed by laterality, sex, and age. And the postoperative variables with the largest maximum potential predicted effect on return to driving time was the 15-second 3-dot touch, followed by the 30-second step up, 25-foot walk, and the preoperative KOOS when it comes to postoperative variables. Interesting. The physical performance measured as a maximum potential predicted effect, 2.9 days, and significant improvement were seen across all physical performance maneuvers between the 2-week and the 6-week visits. So when comparing 2 to 6 week, they did better by 6 weeks, which is no surprise when it comes to total knee replacements. The 2 weeks KOOS was actually significantly improved compared to the pre-op KOOS, which is pretty fast. Most people say it takes longer than that to recover. And subjects responded that they did receive return to driving instructions from their care team, ended up actually returning to driving later than those who didn't receive return to driving instructions. So you got instructions, it actually took you longer to get back to driving, which is counterintuitive. So if you want to check it out, this is the meat and potatoes. Go to www.tkadrive.com. Again, www.tkadrive.com. And check it out. You can click on preoperative. You can click on postoperative. You can enter these different factors in. And it goes through all the things we were just talking about now. Age, sex, surgical side, pre-op KOOS, and all these different tests, the 30-second step up, unidirectional timed up and go, 25-foot walk, 30-second squat to 45 degrees and stand, 15-second 3-dot touch, and walker use during unidirectional timed up and go. And they can give you percentage of similar patients, or 25, 50, and 75% of similar patients who return to driving by day and would give you a day. So pretty neat calculator there. Again, it's available online. It gives you pre and post-operative setup there. The pre-op is obviously very little because all it's asking for is age, sex, surgical side, and preoperative KOOS, and gives you a predictable amount of time. So pretty practical information, I said. I do like this study in that it does give you concrete numbers to discuss your patients. It has to be validated. It has not been done in other institutions. This is just one patient population. Clearly a pretty healthy population to be staying for such a short period of time. And for, probably ASC-like setting patients. So definitely to expand it to more cohort of patients. But interesting data nonetheless, and would be neat to see if the calculator changed over time.
Certainly check out the website if you want to learn more and you want to play around with it. But I think it should have the pay-for-play call service, annotation, caveat. This is for entertainment purposes only. Like Miss Cleo, like when they would want, those advertising. I mean, we're going back to like the 90s here. We're dating ourselves. Our audience, we're all, peers here by and large, right? They would want you to call to, get a message from Freddy Krueger or like the New Kids or whatever. Miss Cleo, get your fortune told. And they were always like for entertainment purposes only. This, like you said, the single most important thing is that this has not been validated prospectively in other populations. I think it's a fairly small sample. 167 patients is really not that many when you talk about the entire universe of patients that could be presenting with various intersectionalities in terms of their problems, knee function, ability, recovery. I think it's an idealized population, like you said, that this is going to be the leading edge of people who are able to drive. So maybe it's showing like the earliest people can get back to driving, but not necessarily the average. Do this in 1,000 patients. Do it in patients that are in not ASCs, but in tertiary medical centers because of other risk factors, frailty, comorbidities. You're not going to get, I would wager you don't get these results. And then we just come back to, they had me at factors that influence returning to driving following primary total knee arthroplasty or prospective investigation, like they said in the title. I was like, this is great. And then they said, we're going to do a risk factor calculator. And I was just like, the Dude and Brandt paradigm. No, don't say that. Don't say that. Do we need a calculator for returning to driving? Like, we can just tell patients off of this. we could just tell patients off of this that, the average time was about 18 days, which actually isn't that far off from 3 weeks, which is what you're telling patients without the benefit of this, right? So I think that pretty well aligns. And I don't think going in and doing the calculator is going to give you, I think there's going to be obviously based on many of their findings and the fact that we won't even touch on presenting univariate analysis as the main results.
Right.
Univariate, really bivariate, these are unadjusted, they're not accounting for other factors.
No, they're really not. So,
right. So the calculator is not measuring a composite. It's not looking at the patient as a 360. It's just looking at each of these individual things. Exactly.
And then so you just want to do an aggregate and just tell them when they're there, saying, this is what your estimated time of returning to driving is, period.
Right. It's and so there's just not enough variation in their model to account for the older person who maybe has visual impairments and is diabetic and pre-surgical, limited mobility wise, but still driving, of course.
It's still driving.
It's not going to count. It's not going to count for those. It's not going to perform well in those people.
Yeah, agreed. Need more variables or need more diversity of people.
Yeah, it could be drastically different in a substantively different population.
Totally agree.
I think it was cool and useful, right? You could have cut it at doing the calculator.
Totally, unfortunately agreed.
All right. You thought that was maybe your case is on hold featurette, but it's not. We got a different one. See if this is going to go on hold. Weight loss before total joint arthroplasty using a remote dietitian and a mobile application, a multi-center randomized controlled trial. Now, when this was selected as your case is on hold featurette, it's by Stewart and colleagues. There's a commentary, an infographic, and 30 days free. So your case is on hold perfecta, not the trifecta, but the perfecta. But when this article was selected, I didn't realize that you were the senior author on it.
That's why I was like, let's see how this goes.
So I made all my comments and then realized that you were the senior author on it.
Be honest, my friend. That's what we're here.
We have. Oh, don't worry. I'll be honest. No concerns there. We've had people, reach out and send us, and they say you should have the authors come on. And there's a variety of reasons why we don't really do that. But in this case, here you got your wish.
We're here.
Your wish has been granted, like Zoltar.
Ready,
and just for like in discussion. The movie Big, maybe now you hope it was.
Touche. All right. Wrong.
So this is an article that was conducted in the Preoperative Weight Loss Consortium group and a multi-center randomized trial, including 60 subjects who had a BMI within the 40 to 47, within that range, scheduled for primary total hip or knee arthroplasty over the course of September 2019 to January 2023. Were you adversely impacted by COVID in terms of enrollment numbers?
Absolutely. Big time. It took us longer than we anticipated. And the hardest part was we were bringing people in to weigh them and they couldn't come in anymore. So, in terms of a little author tidbit, we have to weigh patients. We had to actually pivot. We had to get an IRB approval, et cetera, to mail scales back home to patients. They would take a picture on that scale and then send us a picture.
So I thought it was very thoughtful. Like, obviously, the reason that it wasn't BMI over 47 was there wasn't really enough time to safely lose weight over the 12-week study period. Subjects who were deemed eligible were shipped a bathroom scale, all verified their BMI, sending a photograph during a weigh-in, or by measuring their weight at a healthcare facility. They were then randomized into two arms with a ratio of 1-to-1 in blocks of 4, and treating surgeons and staff who measured weights were blinded. Weight measurements were then collected at baseline, 6 weeks and 12 weeks, and you had close to 90% follow-up. So that's great. Surveys were collected at baseline and 12 weeks. So, really a short study. Primary outcome was 12-week change in weight. We should say, of course, the control subjects received standard of care, and then the intervention subjects, of which there were 31, completed video calls with dietitians and used a mobile app for the 12 weeks preoperatively. So ultimately, the intervention subjects lost more weight. They lost 2 kilograms more than the control group, but not significantly different. And there was the intervention group lost or had a reduction of 1.4 BMI points versus right around 1 for the control group. And again, that was not a significant difference. The intervention had higher odds of achieving a BMI of less than 40 as a point estimate, but not significantly different. The intervention was favorably reviewed by those who participated, and the preoperative weight loss intervention was deemed feasible and viewed favorably by the patients, but certainly in the context of this study was not found to show a significant difference in any of the outcomes. And what I would say, and what struck me is, maybe if it was longer, like 12 weeks is a relatively short period of time. Maybe if the intervention went for longer, there would have been more something greater, or you'd see more differentiation between the groups. Because honestly, the control group is ostensibly trying to lose weight as well. They were instructed, your BMI is over 40, you're trying to get to under 40 to have the total knee replacement. So they have an incentive to lose weight as well. Especially in the abstract results, the emphasis seems to be on, yes, there were superior results on all these fronts. And of course, it's recognized these are not significantly different, but also they don't seem that clinically profound to me. Like a difference of 2 kilograms. And I would say the BMI minus 1.4 as compared to minus 0.9 is a distinction without really a difference. It's basically, if you round it, they both lost 1 BMI point.
And that's what we struggled with the study. We think that you're right. Over time, we probably could have achieved a little bit more. It wasn't a significant amount. I think the idea that our take home here was that there was another way to lose weight. Whether or not it's the most effective way to lose weight, hard to say. But that, in the era of the pandemic, actually having a remote dietitian, which weren't that popular at the time. I think during the pandemic, it became a lot more popular to do so, or just remote services in general. So this was started before the pandemic, where it really wasn't a popular thing to have remote dietitians. And all of a sudden, it's okay too. So, I guess it's timing is everything, right? And so if this was done way before the pandemic, then it may be like, oh, this is really interesting information. We start implementing this in practice. Post-pandemic, people are like, a lot of things are remote now. So less relevant in that way. But our thought processes were, one, it's obviously still worth putting out there to say, hey, look, this is something that is an option for people. Two, in some ways, it might actually level the playing field. So, for example, going to drive in, going to a dietitian, getting an appointment with someone, et cetera, might be cost prohibitive, maybe resource prohibitive, and maybe difficult for someone to do, versus a remote dietitian might actually be a better or easier resource. It might actually be more cost effective, not just from a transportation standpoint, but the amount of money you're going to pay for it could be as useful as well too. So things to highlight in our patient population, especially patients who come see us for total joints and are obese and need to lose weight. It's a variety of people who come to see us, but some of those people may not have means to go see a nutritionist. And so this would be another option to do so. I know the free service we provided, so that was also nice for patients as well.
I was also struck by the fact that only 10% of the subjects actually underwent total joint replacement within 6 months of the study enrollment.
Yeah, it's one of those interesting things where I found that, one, because I think the pandemic push things out to some degree, right? Like a patient was scheduled for surgery and ended up rolling them out for however long time frame. Two, you'd be surprised at how many total joint patients come in and see you in February, March, and they're like, well, I want to get through the summer. So I'll do it in September, or I'll do it in October. And so, if it's not, even if it's not a weight loss thing, right? They're just kind of like, well, I want to enjoy my summer or something. I have trips planned or something like that. So it's interesting to see people. It truly is an elective procedure. But then the flip side, you get patients who go like, I need surgery tomorrow, but it truly is an elective procedure.
All right, getting to the honorable mentions, because I think we're running short on time. This is 4-amino promotes BM2 expression and accelerates tibial fracture healing in mice by Allure and colleagues, with a comment, infographic and 30 days free. This work in part comes out of the Pennsylvania State University. which is struck me. My daughter will be attending there in the fall as a freshman. So that was a fun little connection. The goal here is to evaluate delayed bone healing as common in orthopedic clinical care, and looking at agents that alter cell function to enhance healing. This is an animal study, obviously, as contained in the title. And they looked at the impacts of the 4-aminopyridine, which they found significantly upregulated BMP2 gene and protein expression and gene expression of all those other genes that you always studied before you took the step one of the board. So if you don't know any of these, and it's around that time, get into that Miller review course. So we got the two promotional fronts in this episode. So RUNX2, OSX, BSP, OCN, and OPN. And they found that the 4-aminopyridine increased the healing rate, biomechanical properties, and endogenous BMP2 expression in tibia following fracture. So an encouraging basic science study there. And then we have another basic science adjacent. Glutamine promotes rotator cuff healing by ameliorating age-related osteoporosis, by Wang and colleagues, with a comment. This is 48 female Sprague-Dawley rats groups with a sham surgery, young and aged, and then rotator cuff repair with fibrin and with the glutamine. And then they used micro CT to look at bone quality in the proximal humerus. And osteoporosis occurred spontaneously at the proximal humerus as the rats aged. Glutamine supplementation effectively mitigated age-related osteoporosis and enhanced the repair in the elderly rats. This supports the potential of glutamine, the most abundant amino acid in the body, as a valuable therapeutic intervention for improving rotator cuff outcomes. And then we have association between tourniquet use and patient-reported outcomes following total knee arthroplasty, a multi-center comparison by Gibbs and colleagues. This is from the Pepper investigators. You're a Pepper investigator, right?
I am a Pepper investigator.
So this is you're technically on, this is the Antonia Chen special issue of JBJS.
just by association.
Right. Well, you're listed in the corporate authorship. They got the asterisk there. So this is part of the Pepper trial, where they have 5,684 patients undergoing primary total knee, of which 86% underwent surgery with a tourniquet, and then 14% without a tourniquet. The percentage of patients achieving minimal clinical important difference for Coos Jr. Was assessed. There were some short-lived findings, and ultimately they conclude tourniquet use was associated with more patients achieving the MCID for the Coos Jr. at 1 month compared with no tourniquet use, but this difference disappeared at 3 and 6 months. At 1, 3, and 6 months, there were no differences in opioid use, healthcare utilization, or complications. Ultimately, they state arthroplasty surgeons could use these data during preoperative discussions regarding tourniquet use as it relates to surgeons' preference and how it could influence postoperative function. So we're about out of time. We'll try and do better next time. Hopefully you enjoyed what you heard. If you did, like and subscribe. Come back in 2 weeks. Dr. Chen will be leading things up. If you didn't, thanks for sticking with us this long. I don't see how you couldn't enjoy this episode, honestly. I think if you didn't enjoy this episode, listen to some other ones because maybe you're just looking for something different. But I don't see this. This is. I feel so good about this episode at the end of this, and hopefully you do as well after listening to us. And you're going to come back in 2 weeks. So until then, as good as you might feel, hopefully you're ready to go and do your case. If not, then you'll just be stuck with here, where everything is always on hold.
Enjoy your hold time.